All right, so today's Roach 250 webcast, we're going to talk about atypical pneumonias, P450 drugs, and the system associated, and then the concept is ARDS. And this already isn't working. Fantastic. What's wrong? Why aren't you working? There we go. You're not to screen. Well, whatever. Okay. So, we have different types of pneumonia here. We're going to be talking specifically about the atypical pneumonias, but just wanted to go over. So, lobar pretty much sounds just like it presents. You've got consolidation, which can involve either an entire lobe or an entire lung. So like you can see here in this chest x-ray. Oh, by the way, I won't mention what textbook we are getting these things from, but it rhymes with thirst paid. All right, so we have lobar, which you can see here, can either on a chest x-ray show up like consolidation, or if you actually were to do a lobectomy or see on pathology, that can involve an entire lobe. We have bronchopneumonia, which is seen as patchy distribution. So as you can see on this slide here, you can just see patches of this broncho patchy pneumonia. And then this photo here is just showing that you have inflammatory infiltrates such as PMNs or cytokines that will cause that. And it can involve one or more lobes. So then the topic of discussion today is interstitial pneumonia, where you have diffuse interstitial appearance on chest x-ray. You can say, ground glass appearance, and it can be bilateral. Again, it can involve more than one lobe. And I wish I had, prepared more. But on chest x-ray for this guy's bronchopneumonia that's patchy, you would see something more along these lines, whereas on atypical, you see it again diffuse and everywhere. And then so we'll talk more about this, but this is the one. This is the one that's more typical for like the walking pneumonia. So, do you guys remember what type of organisms we will see lobar pneumonia? Strep pneumo is the most common. What other ones might we see?
Klebsiella.
Yeah. We can also get Legionella, which isn't just treatment, it's in a different category, but you can't see lobar with Legionella. How about bronchopneumonia?
Strep pneumo again.
Correct.
Klebsiella again.
Correct.
H influenza.
Right. And typhoid. How about the atypical pneumonias?
Mycoplasma.
Mycoplasma.
Chlamydia.
Chlamydia.
Legionella.
Legionella, right. And you can also get the virals, RSV, CMV, influenza, adenovirus. Okay, and then we've also got this guy here at the bottom, cryptogenic organizing pneumonia, which used to be known as BOOP, bronchiolitis obliterans organizing pneumonia. So this isn't an infection. This is more of an scarring post-inflammation. It says etiology is unknown, but it's normally seen from like chronic diseases, like you have rheumatoid lung, or you could have what I'm learning is like crack lung or sarcoid lung. So it'll be like a systemic disease that will end up affecting the lungs. And again, this bronchiolitis obliterans is what you see because the bronchioles themselves are just getting destroyed. And of course, medication side effects like amiodarone, what might be some other drugs that could probably cause this type of fibrosis or an inflammatory disease of the lungs?
Well, doxorubicin, but that's just because it's... No, sorry, bleomycin.
Bleomycin, there you go.
Sorry, that's dilated cardiomyopathy.
Okay.
And
there's a big one. First letter's M.
Methotrexate?
There you go, methotrexate. And we've also got busulfan. That's another one. Another thing, we actually saw a patient with this today. You can have GERD lung, where you get like a chronic pneumonitis because they're aspirating GI fluid or gastric acid little by little into their lungs, and it's just scarring the crap out of them. So this would be another what you would see, because it's not an infection, it's more of like a scarring. Okay, so some of the atypicals, I'm only going to be quizzing you guys on a few things here, but just some of the key facts. We got a gram-negative rod, and you need a silver stain to be able to visualize it better. And it grows on charcoal yeast extract. And then iron and cysteine is included in the medium. So you can use this. Think of a French Legionnaire with a silver helmet sitting on a campfire with charcoal with his iron dagger, and he's no sissy, if you want to. So you use urine antigens, and the labs may show what?
Their potassium levels. Altered.
Not potassium.
Sodium?
Which way, up or down?
Increased sodium?
Low sodium.
Hyponatremia. So again, like we all know, that Legionnaire's disease is spread from aerolization of the disease, like famously in the cooling system at the Legionnaire's convention. So it's an inhaled type of pneumonia. So it is not something that is transmitted by person to person. So what will be the treatment for this disease?
Fluoroquinolone, aminoglycoside,
Macrolide.
Macrolide and quinolones, right. So wait, because these guys stain poorly, that means that their cell walls and cell membranes are not the typical ones, so we need an atypical drug. Just a penicillin won't work. So again, it could be a unilateral or a lobar type of pneumonia, and it can also be interstitial, like we said. So this can present in just about any way, and you're going to have fever, GI, and CNS symptoms, and it's very common in smokers and in people with chronic lung diseases. And then Pontiac fever, this is the milder version of this syndrome. I have never seen a question on it. I just remember from Dr. Who was the micro teacher?
Santos.
Who?
Moscatello?
No, on the island.
Santos.
Oh, Santos.
Santos, yeah. I just remember she always stressed Pontiac fever, and it's like, okay, never seen a good question on it. Any questions on engineers? All right. So now we got chlamydia. So chlamydia cannot make their own ATP, therefore they are what? How would we classify them? They can't make their own ATP, so they are obligated to use
Intracellular organisms.
There you go. Right. So obligated intracellular organisms, and so they can cause a bunch of types of infections. But this organism has two different forms based on its its current mechanism of action, what are those two forms? There's an E form and an R form.
R is reticulate body.
Right? It's the E.
Just remember
The
infectious.
elementary bodies. So the elementary bodies are the one that cause the N infection. These are the ones that are traveling from cell to cell. And then once they endocytose into the cell, that's when they transform into the reticulate body, which replicates by fission. And then once they have, completely colonized the cell, they turn back into elementary bodies, and then they continue on invading. So some of the diseases that we see with chlamydia trachomatis, which we're all familiar with that one. As we can see here, you get the nasty trachomas. And I guess you can get reactive arthritis with it as well. And then urethritis, PID. So the typical, you got the clap. Now what we're talking about is chlamydia pneumoniae, which is again atypical pneumonia. So you're going to be seeing this one as an interstitial diffuse lung pattern on chest X-ray. You can also get chlamydia psittaci. Where do we see that one from?
Animals, or like parrots or turkeys.
Yeah, I know it's right here, but still good to review. Excuse me. So how might we also treat this?
Macrolide.
Azithro specifically.
Or?
Doxy for a week.
Right. And since we're treating for chlamydia, what might we also give a patient? Because we're also going to treat him for something else.
Gonorrhea.
So what will we give for gonorrhea?
Ceftriaxone.
There you go. Very good. So the reason we do this is because the cell wall lacks peptidoglycans, so any kind of beta-lactam antibiotic is ineffective. Anything else here? You guys got any other questions on this one?
Nope.
All right. Now, Mycoplasma pneumoniae. So this is one of the more common types that we'll see from an atypical bacteria. And this is the walking pneumonia. So this, how would whatever I want to say. So the X-ray looks worse than the patient. So the patient might say something like, "Oh, doc, I feel a little ill," but their chest X-ray will look like they've got, TB or something. It just looks horrible. And so the X-ray looks worse than the patient. So what is, if you were to do titers of these
IgM?
Yeah, what do we call those in Mycoplasma?
Warm agglutinin, cold agglutinin.
There you go. Right. Right. So how might we treat this atypical pneumonia?
Macrolides or doxy.
And fluoroquinolones. So you can add those. Right. So, and again, penicillin ineffective because they don't have a cell wall. So it's not seen well in gram stain, again, because they don't have a cell wall. And they have sterols in their membrane. So it's more common in patients our age. And you're going to see it in places where people are in multiple numbers and in close contacts. Military boot camps, prisons, treatment facilities, even hospitals or college campus or college dorms, camps, like summer camps, that kind of thing. So normally if you're thinking of close contacts and Again, X-ray looks worse than the patient. You've got to be thinking this one. That's why they call it the walking pneumonia, because this patient should be sicker based on his chest X-ray. All right. So, the P450 system. So, essentially, we take something like aspirin, or we take something like some tequila, or, even if you swallow some kind of poison, most of these items will pass through your liver, where they will get their first pass of metabolization, and then they'll move on to more peripheral areas of getting metabolized, whether it be kidneys or gallbladder, or whatever have you. But there's this very specific set called P450 enzymes, which can either accelerate or withdraw the normal natural liver metabolism. And this is this is important because we need to know which drugs can either speed up or slow down that metabolism, because it can affect other drugs and their metabolism, and we will have to adjust accordingly if we are co-prescribing these drugs. So that's the general idea of the P450 system. So everybody understand how that works. So again, very quickly, if you have a drug like, let's say, ketoconazole. All right, so we got this. Let's say somebody has some kind of fungal infection. So they have this, they're just taking this drug. But then the patient is a chronic drinker and smoker. So ketoconazole is an inhibitor. But these two guys are P450 inducers, meaning smoking and drinking will increase the metabolism of ketoconazole, meaning there will be decreased amounts of ketoconazole. So in this scenario, you could say the patient has some kind of fungal infection, and so the doctor prescribes them a 10-day course of ketoconazole, let's say. But this guy is a chronic drinker and smoker, and he comes back to the doctor after his course and says, "Doc, what the hell? His drugs didn't work." Well, the ketoconazole didn't work because his habit of smoking and drinking increased the metabolism of this drug. Does that make sense?
So, are you looking at just this could also affect just regular drugs that you're taking, like warfarin, right?
Absolutely.
Warfarin therapy. Okay. So it's not just between inhibitors and inducers by themselves.
I just used well, again, it would be accentuated here because this is an inhibitor and this is an inducer, so you might have some crossing there. But yeah, this could have been Tylenol. Could have been anything. But you pose a good question, Yash. And on top of the fact that you have certain drugs that are either inhibitors or inducers, you also have drugs that are just susceptible to this inhibitors or inducers, but they don't manipulate the P450 system. They are only affected by manipulators. Does that make sense?
Mm-hmm.
So these can be the ones that are affected by inducers or inhibitors, but they don't necessarily do any of those.
So if I remember correctly, because I don't have fun, so like a fibrate, I'm pretty sure fibrates aren't either inducers or inhibitors, but they are very susceptible to inhibition or induction of the P450 system. So that's something you got to watch out for. Like if you have a fibrate and you put them on like erythromycin, you got one that's an inhibitor and then one that's just susceptible to it. So your fibrate might be, twice as high because of it. So I don't have the list of those susceptible drugs. Maybe at the end we can find that in the farm section. I know it's in there somewhere. But before we go on with that, does everybody at least get the general idea of how the P450 system works, so that we can, go over which ones are which?
I'm good.
All right, so we got the inducers. So the mnemonic that I remember from Kaplan is smoking and drinking in Barb's car with John and Mo will riff her fun and make it greasy.
Chris,
So,
you're floating.
well, let's go down the line because that's just how this PowerPoint's working.
Smoking, drinking, barbiturates,
Carbamazepine.
St. John's worts.
The
Um,
heck is that?
It is a narcolepsy drug.
Mofetil?
Close, modafinil.
Modafinil. Rifampin.
phenobarbital.
Barbital. And graciopolin.
It's phenytoin, actually.
Oh.
Phenytoin.
Phenobarbital is also in
You're right, actually. Yep, you're right. Phenytoin and phenobarb. Ooh.
That's a tricky one. There you go.
There you go. And then you already said graciopolin. So there are the nevirapine and he just phenobarbital. So this isn't a complete list, but this is a good one to get you started as far as knowing a few of them. Okay, and then for inhibitors, I've got pies drink their grapefruit juice with Coke and Fike. Sounds like a real party. What are these?
Okay. So we're starting with
PIs are just a generalized class of drugs.
So proton.
protease inhibitors.
Yeah, Tulsi's got protease inhibitors like ritonavir, lopinavir.
And then grapefruit juice. Cimetidine. Omeprazole.
Nice. Yeah.
Ketoconazole.
Yeah.
Erythromycin.
Yep.
Valproate.
Yeah, nice.
Isoniazid.
Yes. And finally,
Others use
Chloramphenicol. Cipro.
there you go. I was like, but again, this is not a complete list. I also have your sulfonamides, quinidine. What else is in this list? Amiodarone.
Yeah, I had a question on that amiodarone.
Oh, really? Ooh.
Yeah, and I'm like, what the heck?
Yeah, so, I mean, the questions can be pretty limitless with this, but again, you don't need to memorize all of them if you have a pretty good idea of, or just a basic list in your head, then, you're going to be off to a good start. Because actually, dude, I'll tell you this, there's 2 doctors that work in the clinic that work at, and the one, she never knows this stuff, and she'll keep, asking my preceptor, hey, I can't mix these, right? And he's like, you should know this. So it's pretty funny. So you even forget it at that age. All right, so our topic for tonight is ARDS, acute respiratory distress syndrome. So it's a diagnosis of exclusion, and the characteristic presentation of the patient is what?
trouble breathing.
Okay, well,
Respiratory failure.
yeah, so you can have a patient in distress within 1 week of alveolar insult. So, what are some of the typical presentations of alveolar insult?
Pneumonia.
Pneumonia, infections in general.
Sepsis.
Sepsis, yes.
Second question on this. Aspirations.
Yes, I think that might fall into the pneumonias and infections category, but yeah.
Trauma.
Right, like a car accident is I'm pretty sure the very first question on the UWorld Form 1, if I remember correctly. And there's one more that's not always intuitive, but it is one tested frequently. Acute pancreatitis. So yeah, we got sepsis, trauma. Oh, you're right, aspiration, pneumonia, and pancreatitis. Okay, so what is the mechanism? We're starting it off right here with endothelial damage, and what happens from there? So let's go with
capillaries become permeable, and then proteins leak out.
Right, so we got increased alveolar permeability, proteins leak out, and but what causes the alveolar walls to rupture and leak out, and the proteins leak out? What are the cells that break down that cell membrane?
Pneumocytes?
I'm sorry?
Pneumocytes?
I guess it's in the next thing. Yeah,
is that type 1?
Yeah,
type 1. Are they type 1 or type 2?
Type 2 are the ones that create the scar tissue. Are you asking which one releases yeah, type 2. Type 2 cells proliferate during lung damage. You're right. Okay, so it results in the formation of, and then this keyword is frequently like an answer for tests. What is the name of the scar tissue that is formed?
Hyaline?
Yeah, hyaline. Alveolar hyaline membranes. Oh, okay, here it is. Release of neutrophilic substances, which ends up causing oxygen-derived free radicals, because you've got, like you said, you're going to have increased, I can't even think of it, capillary permeability. So then you have all these substances that are toxic, activate the coagulation cascade, free radicals. So that's the mechanism. And you want to keep, the management is you want to have mechanical ventilation at low tidal volumes, because you keep the tidal volumes low so that the alveolar sacs never crunch down on themselves. You want them to remain inflated, but not overinflated, because they're delicate, so they'll tear. We don't want that, but we also don't want them to crumple up on themselves and cause atelectasis. So it's just keep low tidal volumes, or assess the underlying cause, and assess the underlying cause, like pancreatitis or pneumonia, or sepsis, or trauma, or any of them, I guess. All right, so any question with ARDS, and it's always going to show up as a patient that's being treated for pneumonia, a patient that came in after a car accident, and day 3, 4, or 5, after they're stabilized, suddenly they just short of breath and they can't breathe. So that is the main presentation in the vignette.
Type 1 pneumocytes that line most of the alveolar surfaces, so they're going to be the most likely involved as far as the damage. But yes, you're right when you say type 2 is lung damage. So I think both will be high, but I think from what I gathered was type 1 pneumocytes are going to be the primary ones that are going to be involved.
So type 1 is going to get damaged, and type 2 is going to probably be the ones that are going to create this hyaline membrane.
Right, because type 2 serve as precursors to type 1 as well.
Okay.
So I'm pretty sure you're reproducing that type 1 while type 1 is getting damaged.
Mm-hmm. Okay. That makes sense. All right, so to wrap it up, I've got a couple questions for y'all. 21-year-old college student presents to the health center complaining of malaise, headache, fever 101, chills, non-productive cough. It's last week. His temp 101, heart rate 90, resp 20, BP 118/75. On physical exam, the patient appears fatigued. Auscultations of lungs reveals bilateral diffuse wheezes and growls. The X-ray of the chest reveals fluffy bilateral infiltrates. The physician prescribes ceftriaxone, but the patient fails to show any improvement over the next week. What is the mechanism of the antibiotic that the patient should be switched?
Let's see. Doxy.
No, isn't it?
Okay.
Macro.
Macrolide? Okay.
So which
Because we
one?
got, this is
What?
penicillin.
Doxy is going to do what? What's the mechanism? 30S subunit, right? But
Doesn't see.
Yeah, by at 30, so aminoglycosides and tetracyclines. And doxy is a tetracycline.
attachment amino acyl tRNA.
Okay. Yes.
Mm.
Yeah. So
But
that's what
translocation is macrolide, right?
Yeah.
So the tRNA was what I was looking for.
What is which drug is this?
Rifampin?
Yeah. And
The last one was
I guess this could be a couple things.
like a ergosterol?
Yeah. Ergosterol. Okay. So I got a 65-year-old man brought to the ED after developing sudden onset right-sided weakness and difficulty speaking. Has a history of paroxysmal AFib and taking warfarin for the past several years with a stable prothrombin time. His wife adds he started taking a new drug 2 weeks ago, but cannot remember the name. PE shows right hemiplegia, right hemisensory loss, express aphasia, and right homonymous hemianopia. MRI of the head shows a left middle cerebral artery infarct. Transesophageal echo reveals a small thrombus in the left atrium. This patient most likely started taking which of the following? Oh, and I guess we forgot to do this with the last question. We didn't really walk through the vignette, so we can go back and do that. But okay, so this guy comes in with right-sided weakness, difficulty speaking. What's he got? Got a history of AFib.
Stroke.
He's having a stroke, right?
Stroke.
So he's got a history of AFib, and he's been taking warfarin for years with stable lab values. So he started taking some new drug. So obviously some P450 drug is fucking with his normal routine. So the rest of this is all just showing that he has signs of stroke and small thrombus in the left atrium, which is the most typical place for an AFib patient to get it. So which drug? Okay, so actually, before you guys answer, so we got warfarin that isn't working. So does this mean that this man has introduced an inducer or an inhibitor into his drug regimen?
Inducer?
An inducer because it increased
Metabolism.
the metabolism of warfarin, rendering his normal dose not effective, leading to his stroke. So which of these drugs is an inducer? Oh, St. John's wort. The other three are all inhibitors. So if anything, they would have made his blood even thinner than normal. And if he had taken one of those, then the vignette would have been this man's INR was 3 or 4, and he's bleeding like crazy after, just cutting his finger on something. Yeah. Okay, so just going back to this question really quickly. So what does this guy have? He's a college student, malaise and headaches, last week. He's just fatigued. His chest x-ray shows fluffy infiltrates. Right, Myco, he's got a walk-in pneumonia. Right, so since it is an atypical, we have to use atypical drugs to treat this type of pneumonia. But ceftriaxone did not work. Okay, that is what I have for this.
Just a quick question. I have fibrates as an inhibitor.
It is? Okay.
I mean, that's what I don't know if that's accurate. I don't know if you guys have any sort of notes on it, but in my notes, I have fibrates as an inhibitor.
Unless it's in, no, fibrates is in the cardio section, isn't it? Okay, I'll take your word on it. I don't have any note on it, but I'm only going off of
Alright, so
first paid.
I'm not accurate. I'll look into it and I'll get back to you guys tomorrow about it.
All right, works for me. Yeah. So unless anybody has any questions, comments, additional stuff,